So tonight it's my honor and privilege to introduce our guest. He's been here on a number of occasions, and it seems we get him out about this time every year to update us on what's new in drugs in the prostate cancer clinic. Dr. Dean Ruether is a stalwart at the Tom Baker Cancer Center. There's a number of titles and positions that he's held, but personally I can tell you that he's a wonderful clinician with an incredible bedside manner. I think people are privileged to be able to have him as a caregiver and a physician. He's done an incredible job at moving clinical practice at the Tom Baker Cancer Center, and he's done a great job to the lives of a number of people that have gone through this. So without further ado, I'd like you to join me in welcoming our guest tonight, Dr. Dean Ruether.
So it's my pleasure to be here, and I see a lot of familiar faces in the crowd. I want to talk to you tonight a little bit about some of the new drug treatments in prostate cancer, but I thought I'd share with you some other updates in regards to things that are going on in the city and in the province of Alberta in regards to cancer care and prostate cancer care more specifically. So I'll talk to you a little bit about some updates in regards to facilities that are available to patients in need of treatment for cancer, talk about some of the programs we have in Calgary, and share with you some information about a new prostate cancer program. Then I will talk about some of the new drug treatments that are moving into the clinic over the last couple of years, and then we'll have time to take some questions. So you are probably all familiar with the Southern Alberta Institute of Urology and the Prostate Cancer Center that is housed there. All urologic services are housed under that roof, and that is that development over the last 5-6 years is puts us on the map in North America, really, as one of the premium centers in North America for the care of patients with genitourinary malignancies and prostate cancer more specifically. There are, because we have that concentrated effort and group under one roof, we are the largest center in North America that provides care for patients with GU cancers, and prostate cancer being one of those. That creates a lot of synergies, a lot of advantages for patients, a lot of opportunities for healthcare providers to interact when it comes to clinical care and contributions to research and education. Alberta Health Services runs the Tom Baker Cancer Program, and we have satellite clinics right now at the Old Children's Hospital, or what we call the Richmond Road Diagnostic Treatment Center. Some of you may have attended appointments in clinics over at the old Holy Cross Hospital that we had to vacate after the flooding last year. We are moving most of our operations out of the Richmond Road facility and back to the Holy Cross probably sometime in February of the coming year. The Jack 80 Cancer Center in Lethbridge has now been running for a few years with full treatment capacity, including radiation treatments for patients with prostate cancer. Those started in 2010. There are now 2 full-time radiation oncologists there. There were 2 medical oncologists. Unfortunately, we're back down to 1, but we are in the process of recruiting another medical oncologist into Lethbridge. And obviously that creates huge advantages for patients in the southern part of the province if they don't necessarily have to come all the way into Calgary for treatment. The Red Deer Cancer Center is complete, and there are now 2 full-time radiation oncologists there, and they've started doing treatments. They've been doing treatments there now for just over a year, and we are in the process of recruiting 2 medical oncologists into that facility. And so that will create advantages for patients in the central part of the province in terms of proximity of care closer to home. The plans for the new facility in Grand Prairie are ongoing. been a few delays. We had hoped that that facility, if I met with you a couple of years ago, I would have said that we were hoping for treatments to begin there in 2015, but there have been some delays to planning for that facility. So we're now looking at probably 2017 before that cancer facility opens. But again, once that is open, the plans are to recruit 2 radiation oncologists and 2 medical oncologists to that facility. And so care for patients in the northern part of the province will be that much easier in terms of proximity to home. Here in Calgary, we have a number of programs that some of which you may be familiar with, what we call our rapid access programs. So the rapid access one is the rapid referral to a urologist for assessment, biopsy, and diagnosis. We have our education program, RAC2, for patients who are newly diagnosed with prostate cancer and wrestling with the decisions about treatment options. The RAC3 program is the program that provides post-operative care. So if you've had surgery for prostate cancer, the nurses come and meet with you on the unit in the Rocky View Hospital and then organize follow-up visits to the Prostate Cancer Center to look after removing staples and stitches and dealing with catheters. And this has saved, over the last couple of years, over 140 visits to the emergency department for patients that would otherwise have had to deal with the emergency room to deal with issues post-operatively. More recently, we have what we call the late post-operative care clinic, and that provides patients who are a little farther out from their surgery or cryotherapy with a follow-up visit to assess how they're doing and recovering from treatment at 3 and 9 months post-treatment. And we now have what we call the the active surveillance program. Active surveillance traditionally has been done in the individual urologist's offices and is still done that way in many cases. But we now have a coordinated central clinic run by Dr. Eric Heinemann primarily, but he has some help from Dr. Gatto and Dr. Donnelly to coordinate the care that's required for active surveillance, ensure that patients are getting in for their PSA tests and their exams and repeat biopsies. And one of the most exciting parts of this initiative is that it is attached to a research program where we are getting permission from patients to collect samples from the time of their surgery, samples of their tissue, collect urine, blood, and semen samples that are going to benefit us in terms of being able to study prostate cancer. And all patients who go into the active surveillance program are entered into a database that we will continue to collect data on what we call a prospective fashion. So going forward, we'll be able to watch to see what happens to this large group of men who are participating in active surveillance. And then the new program just started in the last 6 months or so is what we call RAC6, or the AMP clinic, the Advanced Metastatic Prostate Clinic. Most care for advanced prostate cancer has occurred either in individual urologists' offices or at the Tom Baker Cancer Clinic, through clinics there. We now have a central clinic at the Prostate Cancer Center, run primarily by Dr. Gatto, for men who are dealing with metastatic prostate cancer. There are some men in those circumstances who don't necessarily need to come to the cancer clinic. I'll be talking to you tonight about some new medications that can be administered easily and orally and can be done through a community program. And this clinic is going to provide that opportunity for men so that they don't necessarily have to be coming up to the Tom Baker Cancer Clinic. And it's creating opportunities for us to work more collaboratively with the urologists out in the community. So a very exciting development, I think. We've added a couple of new educational programs. So I've already mentioned the Rapid Access 2 educational program. We now offer a radiation therapy teaching class. So if you are a patient who's going to receive radiation-based treatment for your prostate cancer, you're booked into a radiation therapy teaching class prior to starting those treatments at the Tom Baker. Many of you probably know about the program called Life After Prostate Cancer that's been run at the Southern Alberta Institute of Urology for a few years now. And that's for patients and their partners who are dealing with the after effects and the consequences of prostate cancer treatment. And then more recently, we've also started offering what we call the Couples Workshop. So that's a program directed at couples who are dealing with the issues that impact intimate relationships that come from prostate cancer treatment. Both of these programs have become quite popular, and we're now offering them on a regular basis. And you don't need to be referred by a physician to attend those. You can call the Prostate Cancer Center and let them know that you're interested in attending, and they'll let you know when the next set of classes is running. And then the newest addition to our group of educational programs is what we call the ADT classes. So for men who are on androgen deprivation therapy and are dealing with the challenges that can come with hormonal therapy for prostate cancer, this program is set up for men who are getting started on that treatment, to educate them about what to expect from androgen deprivation therapy, and to teach them some of the things that can be done to help manage the side effects and problems that can come with ADT. And finally, I want to tell you a little bit about what we call the APCARI program, the Alberta Prostate Cancer Research Initiative. So this is a very aggressive Alberta province-wide program. The chair of this program is situated in Edmonton. But this is an attempt to establish a provincial database and a provincial research initiative. So men who are going to be undergoing a biopsy for prostate cancer, both here in Calgary and in Edmonton, are approached about participation in this program. If they agree to be followed through the APCARI program, then they're entered into a database, and we collect samples from at the time that their biopsies are done, and other biologic specimens, urine and semen. And again, this is going to provide an opportunity to follow a large group of men in the province of Alberta and learn from that experience. And we've set a very aggressive target to accrue 8,800 men to this program over the next few years. Are there any questions about the support programs or the educational programs before I move on to discussions about some of the new treatments?
Just where can you get further information on that so you can actually join the programs?
On which, APCARI or?
You said there was a clinic for those people who are starting on hormone treatment?
The androgen deprivation therapy clinics? Yeah, so you could call the Prostate Cancer Center and let them know that you're interested in the ADT class. Any of these programs, if you called the Prostate Cancer Center and let them know what you're looking for information about these programs, they would be able to point you in the right direction. Any other questions, comments? Okay. So let's talk about some of the new developments in treating this disease. Some of what I will share with you today are updates from the last presentation I did to this group in 2012. So a couple of years ago, when I did a similar talk, I talked to you about the results of this clinical trial, what we call the PIVOT trial, looking at active surveillance as a potential treatment for men with prostate cancer. And at that time, we had the benefit of 10 years of follow-up, a large group of men who'd participated in this study and been randomized to either active surveillance or an immediate treatment. And updates to this data set continue to show us that this is a safe and effective treatment option for men with low-risk prostate cancer. And so it's encouraging to see that data maturing and to see that this is still a reasonable option, that not all men who are diagnosed with prostate cancer need to necessarily immediately undergo treatment. This is a very important trial. It's not the final answer when it comes to active surveillance, but I think there are two really key pieces of information that come out of this study. So for men who fall into the low risk category, who are greater than 65 years of age and have a life expectancy of not more than 15 years, and we can debate how we determine that, Active surveillance is an effective and potentially a safer option than immediately going into surgery because you avoid the risk of the surgical procedures. For men who have low-risk disease and who are greater than 65 years of age and have a life expectancy of more than 15 years, observation looks to be at least as good as going into an immediate treatment. This information doesn't apply as well to men who are younger, and so it may not be as helpful for men under 60 years of age. And for men who fall into the intermediate or high risk category, I don't think that this information is particularly helpful. Those men probably should be looking at an active treatment as opposed to active surveillance. And there are other clinical trials that will report results of active surveillance protocols over the coming years. So let's talk about how we treat advanced prostate cancer. And as many of you are, I'm sure, aware, prostate cancer cells are stimulated by male hormone. So their growth, their division, their spread to other parts of the body is stimulated by male hormone, testosterone. And advanced prostate cancer has for many years been treated by depriving the cancer cells of the stimulating effect of male hormone. That's what we call androgen deprivation therapy. And we can do this either surgically by removing the major source of testosterone, which is the testicles, or we can do it with medications that are injected. The testes are the major source of male hormone. We know that if we eliminate or block the stimulating effect of male hormone, that's effective in managing prostate cancer in more than 85% of men who receive that treatment. And until very recently, that was our standard way of managing prostate cancer. We used androgen deprivation therapy, and we monitored, and if the disease was progressing or stopped responding to androgen deprivation therapy, we went on to other treatments. But recently, there's been and chemotherapy was reserved for men whose disease was no longer responding to androgen deprivation therapy. Recently, this study has been published. It's called the CHARTED trial, and this was a trial that looked at adding chemotherapy to the androgen deprivation therapy when men are started on this treatment. So a large group of men were randomized with metastatic cancer, were randomized between androgen deprivation therapy, the standard of care of the day, versus androgen deprivation therapy and treatment with 6 cycles of a chemotherapy drug called docetaxel. And what the clinical trial has shown us is that the group of men who received the more aggressive treatment with chemotherapy did significantly better. They actually survived. The average gain in survival for that group of men was 13 months. And in cancer, that's a huge improvement. We often see small improvements measured in weeks to months from new treatments in terms of improving patient survival. To see this kind of an improvement from a study is quite groundbreaking. And when they looked specifically at the men who had more extensive metastatic disease, so disease that affected not only the bones, as it commonly does, but affected the liver, lungs, other spots in the body, the potential gain in terms of survival was even more significant, 17 months. And encouragingly, the trial showed us that we could give this treatment to men. They tolerated it well. They were able to get through the treatment, and there were not a lot of downsides in terms of additional side effects. So these results, presented only very recently, have already changed practice. And we are now, for a man who is starting on androgen deprivation therapy for metastatic prostate cancer, we ask ourselves the question, should this man also receive chemotherapy treatment with this drug called docetaxel? And it is certainly strongly recommended for men who have a significant burden of metastatic disease. When prostate cancer progresses on hormonal therapy, we call that development of castrate-resistant disease. So it's progressing in spite of the fact that we've blocked male hormone and its stimulating effect, and we measure a testosterone in that man, and we know that it's well suppressed, and yet the cancer is starting to progress. We call that androgen resistant or castrate resistant disease. And for many years we've had access to what we call peripheral anti-androgens. You may recognize some of these names: bicalutamide, flutamide, nilutamide. These were orally administered agents that could be added to the injection therapy that a man was on. And about 20 to 25% of the time, adding those drugs would produce some response, usually a drop in the PSA, not necessarily clear that it actually meant that patients did better in the long run, but we could see that the PSA fell about a quarter of the time. But those responses were often short-lived. And what we then had to go to was treatment with chemotherapy, the drug I mentioned to you just a couple of minutes ago, docetaxel. We've been using that treatment for castrate-resistant disease for many years now. And that's based on benefits that were demonstrated in clinical trials in the early 2000s, showing that treatment with this chemotherapy drug improved the outcomes for patients with prostate cancer. It helped to control symptoms related to the disease. It improved quality of life. And there was a small gain in survival, but it was measured in a few months, not a huge improvement. We know that many men in this set of circumstances are not well enough to receive this chemotherapy treatment. So when we looked in Alberta, only about 40% of the men who were potentially eligible for this kind of treatment were actually receiving it, either because they weren't well enough to receive the chemotherapy, or they weren't necessarily being referred into the cancer clinic for consideration of this treatment. And so we knew there were missed opportunities for a number of reasons for men in this set of circumstances. Our understanding of the way male hormones impact prostate cancer continues to evolve, and we've learned that prostate cancer cells are smart. They can actually produce male hormone themselves to stimulate their own growth. And it's out of that understanding has arisen some new drug treatments. So you may be aware of a drug called abiraterone. Abiraterone blocks a particular enzyme that's important in the production of male hormone in the body. And this drug is an orally administered agent. It's very well tolerated by most men who take it. And even men whose health may be jeopardized by other health concerns, where we would be concerned about potentially giving that patient chemotherapy treatment with docetaxel, we can safely administer this drug in pretty well almost any set of circumstances. There are some side effects that come with this potentially. It can cause a bit of fluid retention. We have to monitor patients' potassium and their blood pressure. But it's very rare for this drug to cause problems that mean that the drug needs to be discontinued because it's not tolerated. And because of benefits seen in clinical trials with this agent in men whose disease has become resistant to hormone treatment, it has now supplanted chemotherapy with docetaxel as our first-line treatment for men with castrate-resistant prostate cancer. And this, as I said, is an option for almost any patient, even those who wouldn't be well enough to consider treatment with chemotherapy. There's another drug called enzalutamide, another orally administered, often very well tolerated drug. It functions very similar to bicalutamide. It blocks the androgen receptor on cells in the body that bear that receptor, and blocks the stimulating effect of the residual amounts of male hormone that are in the body in men who are on LHRH agonists like Eligard. Again, this can be orally administered. It's a very well tolerated medication. Sometimes causes a bit more trouble with hot flashes and fatigue than the injection therapy does on its own. But it would be very difficult to identify a patient who couldn't potentially take this medication safely. And there are clinical trials, 2 pivotal clinical trials that have established the benefits of this drug in patients who had been previously treated with chemotherapy for their prostate cancer and in men who had not yet been treated with chemotherapy treatment. And with this agent, we've seen, again, important improvements in outcomes related to symptom control from advanced disease, quality of life, and a small improvement in survival. And this agent is now funded in Alberta for patients who have received chemotherapy treatment. It's not yet funded for the pre-chemotherapy indication, but that's coming over the next year to 18 months, I suspect. So these two orally administered, very well tolerated agents represent a significant advancement for men dealing with advanced prostate cancer. As I said, we can administer these safely to just about any patient, as long as they're willing to be monitored and can come into the clinic for visits. We don't risk a lot in the way of side effects, as we sometimes do with chemotherapy treatment. And so disease that we once considered resistant to hormonal manipulation can respond to these new forms of hormonal treatment. So these better forms of hormonal therapy provide a well-tolerated, easily administered form of treatment for most patients, including those who might not have been eligible for chemotherapy treatment previously because they were not well enough for it. And the other exciting thing that the clinical trials have shown us is that using these drugs has delayed the need to consider chemotherapy, often by several months to even a year or two for men in this set of circumstances. And once we establish the benefit of agents like this in the most advanced disease, then the obvious next step is to move those drugs earlier and earlier in the disease course. And so we're now looking at clinical trials testing these drugs in men with earlier forms of prostate cancer. And I suspect what we will see is that these agents will move up the chain in terms of where we use them in patients with prostate cancer, potentially in the environment where we are trying to cure the disease with the potential to improve those kinds of outcomes. These two drugs, enzalutamide and abiraterone, represent a number of other drugs that are out there and in clinical trial development. So there's another agent you may have heard of called ARN-509. It doesn't have a name yet. It's a similar drug to enzalutamide, probably a more potent drug than enzalutamide that is undergoing clinical trials right now. Our efforts in terms of clinical trial development are not always successful. So when I met with you a couple of years ago, I talked to you about this agent, ortoronal or TAC-700, which is very similar to abiraterone, and we were excited at that time that this drug might have a role to play. But unfortunately, it has not panned out in clinical trials. And so I don't think we'll be hearing much more about TAC-700 or ortoronal over the next few years. The other new treatment that you may have heard about is an agent called Xofigo or alpha-radin or radium-223. This is a different kind of treatment. It's a way of delivering targeted radiation therapy to deposits of prostate cancer. So radium, if you think way back to your days in chemistry class, if you look at the periodic table, radium sits in the same column as calcium on the periodic table. And radium mimics calcium in the way that it is handled in the body. And we've been able to take advantage of that property of radium in designing this treatment. So when prostate cancer, and indeed other types of cancer, spread to affect the bones, they cause destruction of bone. The body tries to heal that by laying down new bone around those sites of damage. And under normal circumstances, calcium is laid down in that area of new bone formation. As I said, radium mimics calcium. So we have this form of radium called radium-223, so it's a radioactive form of the agent, and it's laid down in bone around the sites of metastatic deposits of cancer. So as I said, it's a way of delivering a very small, focused dose of radiation to sites of disease in the bone. And this study, called the Alsimka study, has been published recently. So 920 men with metastatic prostate cancer that was affecting their bones were randomized between what we call best supportive care and the radium-223. So it's given by an intravenous injection once every 4 weeks for a total of 6 doses. In the other arm of the study, the men were randomized to best supportive care and a placebo infusion. And what we saw from this trial was a significant improvement in patient outcomes, symptom control, quality of life, and an improvement in survival, measured in several months. And this is the first example of what we call a bone-targeted therapy that has actually been shown to improve overall survival. So we're very excited about this treatment because, again, it's a little more problematic to administer, obviously. It requires visits to the cancer clinic for the infusion of the drug or of the agent, and it needs to be administered in specialized settings where you can handle radioactive material. But it is a very well-tolerated treatment. Not a lot of side effects that go along with this other than the inconvenience of having to come back and forth to the cancer clinic for the infusion. One of the challenges is how this agent is going to be approved and funded in Canada. So with the other treatments that I've talked to you about, the drug treatments, there are established mechanisms through Health Canada and through what's called the Pan-Canadian Oncology Drug Review and the Pan-Canadian Pricing Alliance to bring new drug therapies into the market, cancer treatments or otherwise. This is not a drug. And so we're having trouble finding where this is going to fit and how it's going to be approved. Health Canada has provided their approval, and Health Canada's responsibility is to ensure that something coming into the Canadian market is safe. And they've said, this is safe, we should have access to it in Canada. But where it goes from there is a topic for debate. The Pan-Canadian Oncology Drug Review Program has said, this isn't a drug, it's not our job to review it. Somebody else has to look at this. The Pan-Canadian Pricing Alliance says this isn't a drug, it's not our job to negotiate the price. So the company that manufactures this has approached each of the provincial cancer formularies individually to try and get it brought on board. But we deal with the same issues at a provincial level. If I have a new treatment for prostate cancer that I think should be funded in Alberta, I take that to the Cancer Drug Evaluation Program and make the argument as to why an agent should be funded. I suspect our Cancer Drug Evaluation Program is going to say the same thing. This isn't a drug, it's not our job to decide whether this should be available in Alberta. So it's set to be discussed by the CDE later this month, and it will be interesting to see what the outcome is of that discussion. We've also asked an organization called Alberta Innovates Health and Wellness, who are responsible for reviewing new technologies in cancer care. So we've asked them to provide an opinion on this as well, in the hopes that we can use the information from AIHW and the review from CDE to take it forward to the health minister for funding. So it's coming, but it's going to have a rocky road to get into the clinic, I suspect. And then for the clinicians who work in this area, we're trying to figure out where this fits. How does this compare to the drugs that I've talked to you about, enzalutamide and abiraterone? Is it better? Should it be used before or after those agents? Those are questions we don't have answers to right now. Are there certain circumstances where you might favor an agent like this over an orally administered drug? Those are all questions we're going to have to sort out over the coming years. And again, when you see the benefits of an agent like this in the most advanced form of prostate cancer, then the obvious question is to take it earlier and earlier in the course of the disease and hopefully use it in a set of circumstances where it will improve the potential for cure. And that is a subject of ongoing clinical trials. And we're in the process of reviewing a trial right now that we hope to bring on that will combine abiraterone with radium-223.
Can I ask a question on that? Sure. Is it available in the States?
You know, it's FDA approved, and I suspect it is obtainable. Yes. Yeah.
You're hesitant.
Well, it's very new, so it's got FDA approval. Part of the challenge is getting the mechanism set up to deliver these kinds of treatments. So I'm sure there are large programs in the States that are making this available to people. How readily available that is, I don't know. But
the oncologists here could recommend that to you if you wanted to fit it in with programs that are available here in parallel.
Recommend
to go to the States to have this treatment.
I suppose if you wanted to pay for it.
Yeah, but I realize
Yeah,
it comes at a cost.
yeah, it comes at a significant cost. Yeah, it will be. I suspect it will be priced in Canada so that it is competitive with some of the new drugs. That will be a fraction of the cost in the U.S. I suspect a course of radium-223 in the U.S. is going to be somewhere around $90,000 to $100,000. So
I just had it. I had it finished at about, started a year ago, finished it about 6 months ago.
yeah,
$65,000.
65,000. Okay. Where did you have it done?
In Phoenix,
Phoenix?
Scottsdale.
Okay.
You said 5, I heard it say 65.
65. Yeah.
U.S.
Yeah. Yeah.
It's easy attainable too. It's available in other places pretty easy.
You tolerated it pretty well?
Very well. I had some, I was sick. There were 6 treatments, and I was mildly sick for one of them.
Yeah.
But it took you don't feel anything for at least 30 hours, and then, you know, mild sick. But that was one out of the 6 treatments. 5 of them, nothing whatsoever.
Yeah. When I was here in 2012, I talked to you about this chemotherapy agent, a drug called cabazitaxel. It's sort of a next generation form of docetaxel, and we have had limited access to this agent in Alberta for the last couple of years for men who had previously been treated with the chemotherapy agent that we have been using, docetaxel. And the benefits associated with this treatment are on par with what we've seen with some of these other new treatments, small improvement in overall survival. But it is challenging treatment, probably a little more challenging to tolerate than docetaxel. But we now have, I would say, unrestricted access to it, in that if we feel this is an appropriate treatment for a man with advanced prostate cancer, there are no longer any hoops to jump through to get it. You still have to have been previously treated with docetaxel, because we don't know that it's better than that agent, or Taxotere is the other name for docetaxel. So it's now funded in Alberta for men whose disease has progressed following treatment with docetaxel, and there are clinical trials underway to compare it to our standard of care chemotherapy presently with docetaxel. And we'll probably have results on some of those trials in 2016, 2017. So for men who are dealing with advanced prostate cancer that's resistant to androgen deprivation therapy, a few years ago we had some orally administered agents that might make your PSA come down for a little while, but it wasn't clear that the actual outcomes in terms of how people lived, in terms of their quality of life and how long they lived, was necessarily better. And then we had one chemotherapy agent that not all patients could receive because of the side effects that go along with that. We now have multiple different options potentially to look at, and the advantage of having those kinds of choices, there are a few. Number one, we can try to tailor the treatments to an individual patient. So as I said, there may be circumstances where for a certain man it would be most advantageous to look at one of those orally administered agents. Perhaps for another man it makes more sense to look at one of the chemotherapy treatment options. Or maybe a year or two down the road, radium-223 will be the best option for that man. And then the other exciting thing that comes out of having these choices is the potential to sequence these treatments. So you might go from treatment with abiraterone to treatment with chemotherapy, and then treatment with radium-223, and then on to another hormonal agent. Now, as I said, we don't know yet what's the right, what's the best treatment up front necessarily, what's the right sequence. Is there a best sequence for an individual patient? So we're struggling now with where these different choices fit. But it's certainly an exciting time in the clinic in terms of having access to these options. And with these choices, then there will also be the opportunity, of course, to look at combinations of treatment. So can we give chemotherapy with enzalutamide? Can we give abiraterone with radium-223 and potentially further improve on the outcomes? When I started in practice in 1995, 20 years ago, if I talked to a man about the average survival for a man with castrate-resistant prostate cancer that had spread to other parts of his body, what I would tell that man is that the average survival for a group of men in that set of circumstances was about 13 months. That's an average. Some did better, some did worse. Now, with these agents and the potential to look at a number of different treatments, we're now looking at a median survival for that group of men that is almost 3 years. And that's a change that has occurred over a 20-year period of time. That's relatively short in the history of medicine. So there have been some significant developments in this area that are having a huge impact on what we have to offer our patients. So as I said, one of the next sets of questions is going to be, what about combinations of treatment? I mentioned that we're looking at a clinical trial that's going to combine abiraterone and radium-223. Can we combine the two orally administered agents, abiraterone and enzalutamide? Or what about giving the hormonal agents with chemotherapy treatment? And these are already the subject of ongoing clinical research trials. I want to take a moment to share a little bit of information with you about bone health. Some of you may have heard me talk about this topic before, and I have a partly selfish reason for bringing this up. I need your help. So when prostate cancer spreads to other parts of the body, one of the most commonly affected areas is the bones. And we know that as we get older, thinning of our bones, osteoporosis, is a common problem, and it's in fact a very common problem in men with a diagnosis of prostate cancer. The things we do to men in treating their prostate cancer with androgen deprivation therapy are bad for our bones, thins our bones. So it's very important for men dealing with a diagnosis of prostate cancer, whether they're on androgen deprivation therapy or not, to do everything they can to look after their bones. And that includes making sure you're getting enough calcium and vitamin D. Quit smoking if you're smoking, that's bad for your bones. And weight-bearing exercise helps us to preserve bone mass. But there are drug treatments. There's a group of drugs called bisphosphonates. And these drugs are commonly prescribed in the management of osteoporosis. So you may recognize some of those names there, Didrical, Fosamax. We know from clinical trials in men with advanced prostate cancer that zoledronic acid, one of the more potent bisphosphonates, has the potential to have an impact on patient-related outcomes in advanced prostate cancer. The same is true for an agent called denosumab. Acts by a different mechanism than the bisphosphonates, but it is also used in managing osteoporosis. It can help to obviate the damage that comes from androgen deprivation therapy to the bones. And there are similar benefits in terms of reducing the risk of skeletal complications in men whose cancer has affected their bones with this agent. But at the present time, neither of these agents is readily available in Alberta for treatment for cancer that is affecting bone, or to manage the complications that come from cancer treatment. And this is an issue not only for men with prostate cancer, it's an issue for women dealing with a diagnosis of breast cancer. So I am hoping that Prostate Cancer Canada and perhaps Prostate here in Calgary and in Edmonton will start to raise this issue with funders in Alberta. We need access to these agents. It's a problem across Canada. It's perhaps a little more of a problem in some areas than others, in that there are in some provincial jurisdictions ways of getting a hold of these drugs. But in Alberta, the access to these is not uniform and not what we as clinicians feel it should be in terms of providing the care for patients with prostate cancer and women with metastatic breast cancer. So,
Sorry, isn't Fosamax in West Canada?
Fosamax is funded for the treatment of osteoporosis. It's not funded, and it's used by, these agents are used on different doses and schedules to manage metastatic cancer than they are in the treatment of osteoporosis. So some of these drugs are funded to treat osteoporosis, but they're not funded to treat the complications of cancer or cancer treatment.
So if I went to my GP and said, I would like this to treat my osteoporosis, would my doctor give it to me?
If you've got the indications for it per osteoporosis treatment, then you could certainly get onto that treatment. But the schedule is different.
The schedule of
The administration of the drug. It's given more frequently in treating advanced cancer than it is in treating osteoporosis.
should I just take some?
No. No.
Nice try. Get two eyes.
Demosimab, yep.
Has some pretty weird side effects.
They both have the potential for some side effects that can be very severe. Osteonecrosis of the jaw, yeah. It's a rare complication, but it is an important one to be aware of. Yeah. So there's nothing we do that doesn't have the risk of complications or side effects, for sure. And there are certainly circumstances where we would not recommend this kind of treatment. But I think the evidence still tells us that the benefits outweigh the risks for most patients, and we don't have the access to it that we should. If you develop that complication, potentially it can be dealt with by an operation. Yeah.
Ruether, with the calcium, is there a maximum that you shouldn't exceed?
Yeah.
And another thing, a friend of mine that's more into these vitamins and things says with the calcium, for it to be actually absorbed better in the body, you should be having zinc.
So you probably shouldn't be taking more than 1,500 milligrams of calcium in a day. If you're taking a lot more than that, you increase your risk of problems with things like kidney stones. And in general, if you're going to start taking a calcium supplement, I would suggest you talk with your family doctor about that first. There's some evidence to suggest that calcium supplementation may increase the risk of problems with heart attacks. It's debated, the quality of that evidence. But I think it's reasonable before you start a calcium supplement to talk to your family doctor and make sure that they feel it's safe to do that. It probably is a little better absorbed if you take it with zinc. So I hope I've shown you tonight that we've seen continued improvements in terms of what we have to offer patients and the outcomes in managing prostate cancer because of our growing understanding of this disease, but also because patients participate in the clinical trials that allow us to ask these questions and demonstrate the benefits. And through both the Prostate Cancer Center and the Tom Baker Cancer Clinic, we have clinical trials for all stages of prostate cancer. So if at some point in dealing with this disease you are approached about the potential involvement in a clinical research trial, you should give it serious consideration. And with that, I'll take questions.
Your slide on, you talked about vitamin D. I missed whether you had a dosage level.
Yep, I did. 800 to 1,000, anywhere from 800 to 2,000 units. start with 800 to 1,000, and then vitamin D levels can be measured, and if you're not at a right dose, you can go up from there. Most people are adequately replaced with 800 to 1,000 units in a day.
You, for when a person starts the hormone therapy, and you mentioned that over a period of time they become resistant to it, the disease kind of takes over.
It can, yeah. Not everybody does. But
Yeah, that's my question. Is there a rule of thumb for when that period of time is, or is it radically different for each individual?
It's very different. I mean, some men, small proportion of men don't respond to androgen deprivation therapy. That's a small number. I think if you live with prostate cancer long enough, it will eventually become resistant to androgen deprivation therapy. But I've looked after patients who've been on ADT for 15 years and still have good control of their disease. So it's highly, highly variable.
You talked about metastatic prostate cancer.
Mm-hmm.
Is it metastatic after it's outside the capsule, or does it have to be in the bone before it's classified as metastatic?
When we talk about metastatic disease, we're talking about disease that is spread outside the prostate to other parts of the body, to lymph nodes in the abdomen or pelvis, or bones, or liver or lungs.
Anything outside of the prostate?
Outside of the prostate. If it's just in lymph nodes in the pelvis, we refer to that as locally advanced disease, and it's debated whether that is disease that is curable or not. Certainly we can treat it, but people argue whether you can cure that type of cancer or cancer at that stage. When we talk about metastatic disease, we're usually talking about disease that is more advanced than that.
Is intermittent ADT still the recommended protocol?
Recommended? I'm not sure. I think there are arguments to be made for both continuous and intermittent treatment. I think it's an appropriate option for many men, but there are certain circumstances where we might not be as comfortable with intermittent therapy, and you do have to commit to the monitoring that's required for it. But yeah, I think it's a reasonable option for many men.
Pros and cons of one versus the other?
Well, the reasons that people looked at intermittent androgen deprivation therapy was the desire to get away from dealing with the side effects. So the break from treatment and the break from the side effects of androgen deprivation, and the hope was that that would be associated with equal outcomes in terms of cancer control and better quality of life for patients because they were off the treatment for various periods of time. When you look at the trials that have tried to answer those questions, in the right patients, the cancer outcomes are equal. Intermittent therapy hasn't resulted in as much improvement in quality of life as we had hoped to see. So I think there's a potential for, it can certainly be used. I think there's the potential for men to benefit from it in terms of their quality of life, in terms of getting away from the side effects. But it isn't as great benefit, at least from what the clinical trials tell us, as we might have hoped.
If you've been on intermittent, and you want to perhaps the side effects, one doesn't have many side effects.
Yeah.
Is it valuable to come back to see your oncologist and say, perhaps I should be on it on a prolonged basis?
One of the advantages of the intermittent therapy is that it may limit some of the side effects in terms of effects on bone health. So if you're tolerating it, some men find intermittent therapy more difficult because the going on and off the hormone treatments, they find that a bit of a roller coaster ride. So I've had some patients who said, you know what, my quality of life isn't any better, I'd just as soon stay on this, at least I know what I'm dealing with. If that's not an issue for you, then I think there's maybe some reasons to stay on intermittent therapy in terms of protecting your bones. But if you're anxious about being off treatment, I don't think there's a good reason to be, as long as you're being monitored. But some men have anxiety about that, and they just as soon stay on it. And I think that's quite reasonable.
Just
this morning I was reading a paper and it suggested that overall survival patients pre and post chemotherapy with abiraterone or enzalutamide, that there's a longer overall survival post chemotherapy versus pre-chemotherapy use of that. Can you comment on that at all?
Yeah, you have to be a little careful about those kinds of comparisons because those are different patient populations. So there may be other reasons why men who have not had chemotherapy treatment might do better or worse. So in general, it's probably better to use an effective agent earlier, but you're comparing two different trials and two different patient populations. So you have to be cautious about those kinds of comparisons. I think they allow us to ask interesting questions. They don't give us a definitive answer in terms of saying that we should definitely be using the drug before chemotherapy because it looks like in the pre-chemotherapy study the outcomes were better.
And does one influence the other in terms of usage? Will one diminish the effects of, say, abiraterone, affect the effects of Xtandi?
We don't have a lot of data to tell us to answer that question right now. It does appear that if you've had one, you are much less likely to get a response to the other. And people debate, are you better off starting with abiraterone and going to enza, or starting from enza and going to abiraterone? I don't think we know the answer to that question yet. You see responses going from one drug to the other, but they're small numbers in both. Yeah.
I just wanted to discern whether it's high-risk cancer or low-risk cancer.
So if we use those terms to refer to localized disease, not advanced disease. Localized high-risk prostate cancer is a prostate cancer that is a Gleason 8, 9, or 10, a PSA, presenting PSA of greater than 20, or a large volume of cancer. So if the cancer involves both sides of the gland or is extended outside the gland clinically, that's high-risk localized disease.
What's the approximate half-life of the radium-223?
You know what? I don't know the answer to that question.
11 days.
How long?
11 days.
11 days? Is that what they told you? Okay. Any other questions?
This, like, as a man grows older, there's less testosterone produced.
Yeah.
And also cancer advances less rapidly because the cell development in an older person, say they're 75, 80 years old. Is my concept correct?
Not entirely. Yes, as we get older, the amount of testosterone we make is less. And yes, in general, it's true that men who develop prostate cancer later in life tend to have disease that is a little less aggressive than men who develop it earlier in life. Does that mean that as we get older, the way the cancer behaves changes? I don't know that that's the case. If you develop cancer as a young person, it tends to be a bad cancer. That's true in general. Prostate cancer, breast cancer, colon cancer. There are often more aggressive diseases in younger people.
Would you recommend taking enzalutamide with abiraterone?
Not outside the context of a clinical trial yet.
Okay.
When you refer to the Tom Baker Center, who determines whether you see a medical oncologist or a radiation oncologist? And is there a
Yeah, it's determined by what you need to be seen for. So if you need radiation treatment, if the concern that's being addressed is one that would be addressed by radiation treatment, then you see a radiation oncologist. If you need drug treatments for your cancer, then you would see a medical oncologist.
And if you've gone to one and somehow the treatment changes, they would refer you across to the other.
Yeah.
Or you could always ask for an opinion from the
Sure, yeah. Yeah.
And that would be permissible.
Oh, yes,
Yeah.
yeah.
Okay.
How hard is it to get referred to a clinical trial outside of the province, in another province?
It's not hard at all. The problem is that we don't pay for that. So you can choose to go wherever you would like to go to participate in a clinical trial, but if any of you have participated in clinical trials, you know that that involves lots of visits back and forth to the cancer program, more scans, more blood tests, more frequent follow-up, and if you're participating in a clinical trial at some other center, then you have to go back there for the trial follow-up. So, you know, we don't discourage people from looking at clinical trials in other areas, and if we're dealing with someone who has a rare cancer, then we might look for a trial opportunity somewhere else for them as well. But it's often, it's pretty onerous in terms of the travel and the costs that are incurred for that patient getting back and forth to the center that's sponsoring the trial.
Most of those clinical trials limits your residence to be within 100 miles.
A lot of clinical trials do. They want you to be within certain proximity to the center, because if you get into problems, you need to be able to get in to see them quickly. So yeah, there often is a limitation in terms of how close you are to the cancer clinic that's offering the study.
My PSA is creeping up, and my doctors still wants to do the blood test every 3 months just to see how aggressive it is.
Yeah.
But I have anxiety about every 3 months. Now, if I want to satisfy myself and want to do the blood test more often, how do I get it? Can I pay for it?
So what I would encourage you to do is go back and talk to your doctor and understand why they aren't doing the test more frequently than that. If we do a test, then we have to ask ourselves the question, what will we do with the result of the test? And if doing the test will change management, then we should do the test. If someone is well, I mean, I don't know your individual circumstances, but my presumption is that you are well, and although the PSA may be going up, you're not getting sick from your cancer, quote unquote, progressing by that PSA rising. Doing your PSA more frequently than every 3 months probably will not change what your doctor recommends to you in regards to when it's time to go on to a new treatment. So rather than doing the test more frequently, what I would say is talk to your doctor and try to understand why are they comfortable with every 3 months.
Well, I can accept that the medical profession opinion is every 3 months is good enough. So I can understand that. But to satisfy to calm my anxiety, I would like to know more often than that. And I'm prepared to pay for it, which is not too much for PSA test.
Yeah.
Like, is there a way to do it? Can I go to a clinic and pay like some money and get it done? Or?
You probably can. Again, I would talk to your doctor before you do that. Because if you do the test more frequently and it shows that the PSA is creeping up, what are you going to do with that information?
I guess if my doctor want to see me every 3 months, then I won't be able to see him more often than 3 months. But at least I can sleep at night.
Will you be able to if you know it's going up?
No, I can't. Yeah. See, right now I'm nervous. It's going up, and my next blood test is a month and a half away. And if I can pay some money and get it done tomorrow, then I know whether it's 3 or 4 or 5. Then at least I don't.
But if the number isn't going to change how the problem is managed, then does it matter if you know that it's going up 6 weeks earlier? Yeah.
Well, when you get that to 10, we'll do this to you, we'll do that to you.
Yeah,
So
but
we're
even
gonna
that,
have at 1, so
yeah.
we're going to get to care.
If you did a blood test every month and you found out that it hit 10 in November, as opposed to learning that in February or March when you went to see your doctor, the outcome in terms of the potential impact and the benefits from treatment are no different.
But if it stay at 1 and 1 and 1 and 1 and 1, then I'll be a happy man. I don't have to wait till next February to see my doctor to find out. Surprise, you're at 1, February.
Yeah.
That's the reason I like to see it more often. Like if I see 1, 1, 1, then I'll go and have a holiday.
You should do that anyway, even if it's going 1, 3, 10. If you're well, go take your holiday. You should not, we never make decisions about treatment based solely on PSA. So that's part of the reluctance to doing the test more frequently. It's never going to be the determinant of what happens with your treatment. It's one of the pieces of information that we look at in making that determination, but it's never the driver.
What would you say is the driver?
It's how you're doing.
Health-wise,
Yeah.
your physical
Yeah.
presence.
Yeah.
Presence of...
Are you well? Are you maintaining your weight, your appetite, your level of energy? Are you having pain? Are you able to do the things that you want or need to do on a day-to-day basis? And if those things continue and are unchanged, then if your PSA is 3 or 5 or 10, is not going to change what I would recommend to you in regards to how we treat your problem. If you come in to see me and you're sick, what's that?
Is the rate of change important?
We look at it, but again, it's not a determinant of when we would say it's time to move on to another treatment. It might say to us, well, maybe we should check the PSA in 3 months instead of 6 months again. But the rate of change is never an indication to change treatment.
Or to start treatment. I mean, the doubling of your PSA, it seems to me something that you watch.
We look at it, yep. Yeah, we pay attention to it, but again, it's not the determinant of when you move on to a different treatment. It's one piece of information that we might look at. All right. Thank you.
Thank you, Dean.